Hello and welcome to Chest Clinical Perspectives webinar on the evaluation of patients presenting with chronic dyspnea. My name is Rick Perez and I am with the Chest Analytics team. With me today is Dr. Victor Test, MD, FCCP of Texas Tech University Health in Lubbock, Texas. Dr. Test was essential in guiding both the research and the white paper for this exciting issue of Chest Clinical Perspectives. In a moment, we will be showing a 30-minute discussion between Drs. Test and Clayton Cowl on this important topic. All mics will be muted during the discussion, but please submit any questions you may have via the GoToWebinar control panel to the right of your screen under Questions. Dr. Test will try to answer all the questions after the discussion.
Hello and welcome to Chest Clinical Perspectives discussions on evaluation of patients with chronic dyspnea. My name is Clayton Cowl, President-elect of Chest, and also serve as chair of the Division of Preventive, Occupational, and Aerospace Medicine at Mayo Clinic in Rochester, Minnesota, and also with a joint appointment in Pulmonary and Critical Care Medicine. With me today is Dr. Victor Test, who is a renowned pulmonologist at the Texas Tech Health Sciences University, to talk to us today about chronic dyspnea and about how that pertains to our latest chest clinical perspectives. Victor?
Hello, Clay. Thank you for the opportunity to speak with you all today about chronic dyspnea and the Clinical Perspectives initiative on dyspnea that we've undertaken. I'm a clinical pulmonologist with an emphasis on pulmonary vascular disease, including pulmonary embolism and pulmonary hypertension. So dyspnea is part of my everyday life. As such, I regularly see patients diagnosed with dyspnea or with the complaint of dyspnea who are referred after having been seen at numerous centers for evaluation of shortness of breath. I think, Clay, you would probably agree that it's quite common to see patients who've been seen in numerous places and told, well, your heart's normal and your lungs are normal, and the patient's still short of breath without a clear diagnosis.
Yeah, I think you're right. It's something that all of us in practice see every day, no matter what type of clinic that we're actually in. I may see someone in asthma clinic that has shortness of breath, but at the same time, I may also see someone in pulmonary vascular clinic also with those same symptoms. So it's something that's critical to our practices and I think important to delve into a little further. So, as we think about it, shortness of breath, it's been reported is the prevalence is about 25 to even 30% in some of our outpatient practices. So it's something that's very common out there. And so Chest decided to dig deeper into this issue through our format of using Chest Clinical Perspectives. So Victor, what were your objectives in terms of really delving into this issue and for doing this project?
Well, Clay, we wanted to understand the frequency that chest physicians assess dyspnea, and specifically, we wanted to understand to the extent that we use clinical measurement tools to assess dyspnea and document the severity of the disease, of the problem. We wanted to identify how often physicians use patient descriptions to guide their intervention or assessment of the disease. We wanted to understand how important dyspnea is in the rank of hierarchy of symptoms to the physicians. And lastly, we wanted to get a feel for the diagnostic strategies that physicians undertake when dealing with dyspnea.
Sure. And for some of the folks looking on that may not be familiar with what is Chest Clinical Perspectives, I've been in conjunction with the staff team here at Chest, we've been able to use this format to look at a variety of different problems across pulmonary, critical care, and sleep medicine to take a deep dive into certain problems by surveying some of our membership and through this series of groundbreaking type surveys. And this is just one of those. Chest works alongside of a number of hand-picked thought leaders to help guide the content of each study, as you well know. And these studies have given our partners in the healthcare community some real insights into what's actually going on from people actually in practice who are, practicing across a number of different areas within the specialty. So, Victor, tell us a little bit about some of the first parts of this survey, in particular, looking at the dyspnea assessment tools that we found really were not widely used. Tell us about that, and what's the best practice here?
Well, Clay, the results of the survey were not completely surprising. I think when we realized that the majority of all of the people who responded to the survey were pulmonologists, it's a little surprising that dyspnea is not assessed in terms of severity on a regular basis. As you'll note from the slide, only 75% of people of the physicians who responded assessed dyspnea in 100% of every patient they saw of the last 10. Mm-hmm. And so that means that 25% didn't assess that in every patient. When you go to patients with pre-existing disease, that percentage of patients who are not assessed for the severity of their dyspnea goes up to 40%. And I think one of the issues there is that this data very strongly suggests that the use of dyspnea scoring systems and scales is actually quite rare. Only 12% of our respondents used it on a continuous basis.
And any insights into why that might be? Is it a time factor, or what do you think?
Well, I think that there are probably several factors at play there. One of which is that physicians are pressed for time, and taking the extra time to document these findings and to procure the data. I think that may be a little bit of misleading, though, because frankly, you and I both know that when we talk to patients with dyspnea, trying to actually quantify through taking the taking of a history can actually take quite a long time in trying to determine what they are able to do and when they develop symptoms. And no small part due to the fact that patients all refer to dyspnea in different types of language.
Right, I think you're absolutely right, Victor, and I think taking extended history and including all the various potential exposures that someone might have is not only tricky to do it in a way that the patient feels comfortable with the interaction, but also can do it in an efficient manner where our ever expanding and busy schedules aren't significantly compromised. So let's take a look at the actual data and evaluating the symptoms of dyspnea. So what were some of your findings in terms of looking at severity of dyspnea with or without pre-existing diagnoses?
Well, I think the interesting part on that segment of our questionnaire and survey was that when a patient has a known diagnosis, physicians are less likely to try to quantify the severity of their dyspnea. I find that a little surprising, but
So we have like pain scores and things like that we're well familiar with. I thought it was interesting that once we have a diagnosis that we sort of forget about that part of it, and so it maybe plays to the fact that maybe it's something that we need to add more to our practice, or to leverage some of the electronic questionnaire type formats that are out there to help supplement our visits. Do you agree with that?
I absolutely agree with that, and I also think that that when we see patients in follow-up or even in initial evaluation, some of the other data that was generated from this suggested that only about a third of respondents actually try to quantify the severity of dyspnea at all. Yeah. And so I think that should be that's a really important part of what we're doing, given the importance of dyspnea in clinical practice.
Yeah, and I would say that, as we mentioned before, it is a strongly prevalent part of our practice in a tertiary medical center, in my case at Mayo Clinic, where people may come from all over the country, and they are focused on maybe one diagnosis or one set of conditions, but really the underlying thing that they're talking about isn't necessarily I have some rare disease, it's I'm short of breath. And I'm sure in your center that's similar as well.
Well, we certainly see patients from a wide geographical distribution. And I think that I've worked in several places around the country, and one of the things that's become clear is that when you're in different places, patients report symptoms in different ways. In Texas, for example, this is the only place I've ever heard this, that sometimes patients will complain that the air goes to right there, and they're talking about shortness of breath. That has not been common in any other place that I've worked. So you have to, objective dyspnea scales where patients quantify things can really be helpful. And I think recognizing that dyspnea is important in the overall outcomes of the patient is truly also key to this initiative as well.
Yeah, you mentioned before that about a third of respondents didn't really ask their patients to rate severity of their dyspnea either at all, and there was a significant proportion that once they had a diagnosis didn't really focus on it anymore. Any insights into why that might be the case?
You know, I'm not sure. I think that physicians often are in a hurry. Once the diagnosis is established, I think they spend less time trying to figure out improvement sometimes. I'm troubled by that, but I think that is a common trend.
Yeah, no, understood. And a lot of times it's just trying to make sure that all the guidelines are being met in terms of treatment, as opposed to eliciting more about the history and maybe even spending more time certainly on a physical examination. So as we looked at the data in the study, dyspnea was ranked very highly relative to other patient complaints. How does that match your experience, Victor?
Well, I think that it matches my experience fairly well. I do believe that physicians and patients put shortness of breath at some degree of importance. I think one of the problems from a patient perspective is that patients often get to dyspnea slowly. So your brain and their ability to adjust so that they don't feel the discomfort of shortness of breath is pretty substantial. So a lot of times they downgrade their symptoms until they're very, very severe. From a physician standpoint, it's well known that chest pain is considered a very important symptom, and in this survey, it was ranked the only symptom that was ranked above shortness of breath in terms of importance.
Yeah.
The interesting thing about that, though, is there's quite a lot of data showing that even in patients with chest pain, the presence of dyspnea results in a higher cardiovascular revascularization rate, higher cardiovascular mortality, and higher all-cause mortality than typical or even atypical chest pain.
Yeah, no, that's very interesting. Well, let's move on to approaches in the evaluation of shortness of breath. And there were some fascinating and not so stunning findings that were identified. Can you talk a little about those?
Yeah, I think that when undertaking the history of dyspnea, these findings, I think, are very reassuring and comforting as to the way the history is being taken. Acute versus chronic, obviously had a very high level of importance among our respondents. Intermittent versus continuous, and also at rest versus exercise. Now, the one area where in our survey where there was a little bit of divergence from this very high level of compliance and seeking out these historical facts was the presence of dyspnea based on position. And it's not clear why that is, or even what the significance is.
Yeah, and I don't know if it's, perhaps in the survey methodology or that, but sometimes we'll ask in the clinic, do you get short of breath just when you bend over to tie your shoe? And so there may be some thoracic or abdominal excursion issues that we can identify by that question, but it seems from the survey that clearly in general practice that's not a common question to ask. One other thing I was going to ask you, Victor, was about use of sort of functional questions. So some people, as you already alluded to, don't really know how to quantitate how short of breath they might be. But a lot of times if you ask, can you climb a flight of stairs, or can you walk a block, or can you lift your groceries in, they kind of attach and understand what you mean. Do you find that in your practice that you use questions about functional studies, or do you go more with a standard approach?
Well, actually, Clay, I do both. I universally obtain board dyspnea rating. I always ask about what their capabilities are. That's very important, particularly in pulmonary vascular disease, where patients come in severely dyspneic. You put them on therapy, and they may actually objectively appear to improve, but still have dyspnea. And then, without a clear idea of what they were doing before and a comparator in terms of actual functional symptoms, won't be able to really tell from a symptomatic standpoint whether they're improved. And an example is where a patient where had previously been having difficulty walking from room to room or taking a shower, and now they're going to Walmart and shopping, but become short of breath when they stress themselves, and they may not separate out how much better they're doing.
Sure. No, good points. Well, the next part of the study talked a little bit about the workup of dyspnea, in particular chronic dyspnea. Did you notice anything that was trending or different that you may or may not expect prior to administering the survey?
Well, this survey actually I felt was very gratifying and reassuring. In the pulmonology practice that of the respondents that we surveyed, they had a very high percentage of basic pulmonary testing, which have a very high success rate in general of leading to a diagnosis. Mm-hmm. I was very pleased with it. I really wasn't surprised by any of the findings in terms of testing. I think the only thing I would maybe, in a perfect world, I would like to see done a little more in the evaluation of dyspnea that was not done as often in the study was a thyroid profile. But based on numerous studies, this is a good base to start in terms of diagnostic testing for the patient with unexplained dyspnea.
Anything else that you might know from your extensive clinical experience of other things we can do besides the thyroid-related issues that you might want to point out to others out there interested in this topic?
Well, I think the most important test, because in my clinical experience, patients above the age of 50 who are short of breath are almost universally labeled as having obstructive lung disease. Patients below the age of 50 are almost always diagnosed with asthma or deconditioning, often without any physiologic basis. I can't emphasize enough the importance of the chest radiograph and even simple spirometry in the initial evaluation of these patients. Statistically speaking, in a number of studies that have been published on the evaluation of chronic dyspnea, asthma was the most common diagnosis and oftentimes required a methylcholine challenge to confirm that diagnosis. Simple spirometry and pulmonary function testing often did not make the diagnosis, and thus I would have a lower threshold for using methylcholine challenge in patients where the diagnosis was unclear. But that's not really first-tier testing. That's second-tier testing in my estimation.
And obviously in all our practices, when a patient comes in, there may be a variety of different complexities that we have to consider. Airway disease versus interstitial lung disease. One of the things that was interesting in the survey was the use of CT scanning, and it seemed like it was fairly prevalent in the standard use. Do you think that was more because these were pulmonologists that are seeing more tertiary level referrals, or do you think that's a trend that we're seeing in the community practices?
Oh, I think it's definitely a trend that we see in community practice. The availability of CT scanning and the quality of CT scanning in some cases is sort of bypassed plain chest radiography. I think there's also generally a reliance on technology and imaging as opposed to physiologic testing that's been building over a number of years.
Mm-hmm. Yeah. Now, one of the other factors that was not surprising but important, the presence of dyspnea itself does it really seem to influence clinical decision making at all?
Well, I was gratified to learn that in our respondents that it absolutely did. It had a very strong impact on seeking additional testing and further evaluation.
Mm-hmm. Interesting. Yeah, and it looks like in the next part of the survey, a cluster analysis, we call it, was performed looking at three distinct type of, I guess, pulmonologists. Obviously we're being lumpers here versus splitters, but they were characterized into three areas, and it looked like they were called evaluators, bypassers, and acknowledgers. Can you tell us a little bit about what that means and how that may affect the practice in general?
Well, first I would put myself in the evaluator group. 27% of our group were what we considered evaluators, meaning that they had a high incidence of evaluation of dyspnea, or certainly evaluated dyspnea at a much higher level than their cohort. They used assessment tools more regularly. They put a higher emphasis on documentation and use of dyspnea scales and rating systems, and they also underwent a more comprehensive initial diagnostic evaluation, which included the thyroid profile and the EKG as opposed to chest radiograph and spirometry. There was a middle group called the bypassers, and they acknowledged the importance of dyspnea but didn't actually pursue evaluation or quantification on a higher level than the third group, which were called, or pardon me, we got that backwards. So we had acknowledgers who actually, about 39% of them who acknowledged the importance of dyspnea but didn't actually quantify dyspnea or pursue the severity of dyspnea and evaluate it on a higher rate than the third group, which were bypassers, which really didn't consider dyspnea to be an important symptom and didn't guide their therapy or interventions at all.
What would you say to that bypasser group? What value added would there be in using, for example, a Borg dyspnea scale or that type of thing?
Well, I would hope that the use of those scales, one, would give them a more intimate awareness of the importance of the symptom on the patient's daytime activities and daily life. I also would like to think that it would then be used to guide additional intervention. I believe that for a busy clinician, taking the extra time to get this history can be consuming, and using these scales might be able to improve the quality of our care for our patients.
Yeah, it seems like, especially if you were to use it sequentially, that someone that may have had a score of X and then it now jumps to a higher level within a relatively short period of time might signal that something is going on physiologically in that patient.
Oh, I absolutely agree.
So it's very, very interesting to see some of the data that were pulled out of this survey. Given all of this, it really sounds like we do have some educational opportunities with some of our colleagues. Do you agree in that regard?
Oh, I absolutely agree. I felt for a long time that and this survey reinforces that we need to improve the awareness of the importance of dyspnea as a symptom and also as a prognostic symptom in our patients, independent of the disease process. I think we also, I would like to use this survey as an opportunity to improve and increase the awareness of the utility of the dyspnea rating scales, whichever one they wanted to use, and using validated assessment tools to keep a follow-up of your patients, because let's face it, those are cheap and easy ways to follow patients. And the last thing is that the survey also demonstrated was that there's a general reluctance to take a multidisciplinary, interdisciplinary approach to the evaluation of these patients. In general, the respondents had an approach of evaluation and then referral to another person rather than a true multidisciplinary approach to the disease. And I think that's been shown over time to have a higher success rate in terms of both diagnosis and management of the severity of the disease.
Yeah, interesting. Well, we've talked a lot about patients, and obviously the focus of all of our care is on our patients. But tell me, what do you think are things that we can actually be coaching our patients to be doing in terms of preparing for a visit so that we can be a better doctor-patient team in order to really elucidate what is meant when they're talking about shortness of breath?
Well, I think the first thing that we need to do is emphasize to patients how important shortness of breath is on their life. Again, patients are acutely aware of the importance of chest pain, but many of them are not aware of the importance of shortness of breath and its impact on their life. It's only when they have very advanced symptoms or an abrupt change in their symptoms do they become concerned about it. I think the other thing is that we can ask our patients to start, sort of objectively looking at what they can do. They get to their position of debility over such a long period of time in most cases that it's just their natural state, and it's only when they reflect back that they can see how much they've changed. We've all experienced that phenomena when a loved one comes in from out of state and sees their loved one for the first time in months and sees such a dramatic change, or we've also seen that on a pretty regular basis in hospitalized patients, where the patient goes out of the hospital and now they're abruptly different, and so the patient notices it.
Yeah.
I think one of the other things is that, and maybe we need to work on physicians and family members as well on this, is less of a focus on the importance of oxygen saturation as opposed to the actual symptom of dyspnea. I can remember when pulse oximeters were the size of a small Volkswagen and were rolled around on a cart, or they were only used in the intensive care unit, and now it seems every patient has one. And so when I ask patients about shortness of breath, they very often are focused more on their oxygen saturation rather than what they feel. And while they're both important, I don't think one should take precedence over the other.
Right, no, absolutely right. And how many times have we heard, well, I just think my shortness of breath just from quote unquote old age, and when in fact there may be actual clinically significant changes going on.
Yeah, or the flip side of that in younger people is, I'm just out of shape and I'm getting too fat.
Yeah, exactly.
Absolutely.
We hear that all the time. So to wrap things up, obviously there was a lot of things that were brought out in this particular edition of Clinical Perspectives, but how would we summarize what the top findings would be from this particular edition of the survey?
I think the first thing is that while many of our respondents felt like dyspnea was important, the majority of them didn't act on it in a way that was proactive or progressive. I think that the emphasis of dyspnea as an important symptom, both with physicians and patients is crucially important. And I think that the other thing is that using an algorithmic and multidisciplinary approach to the treatment and diagnosis of dyspnea should hopefully continue to grow and develop.
So thank you very much for your time, Victor. I'm sure that our viewers very much appreciated your clinical expertise and insights on this particular edition of Clinical Perspectives.
Well, thank you for the opportunity to talk to you, Clay.
Well, on the screen is information in regards to getting your copy of this particular edition of CHEST Clinical Perspectives. As you heard earlier, we come out with periodic surveys, including one scheduled for this coming year, which will be a delay in diagnosis, personalized medicine, and a second edition of shortness of breath or dyspnea in pulmonary medicine. Thank you so much for your time and interest.
Now it's the question and answer session with Dr. Test. So let me go ahead and unmute Dr. Test here. We do have a few questions that have come in, but please feel free to jot your questions down via the GoToWebinar app under the questions tab, and we'll take those questions as they come in also. So Dr. Test, are you there?
I am indeed.
Great. So I think that was a very informative discussion between you and Dr. Cowl. A lot of things taken away. We have 2 or 3 questions here that have come from the audience. So if you don't mind taking a few minutes here and addressing these questions. So the first one is, you discussed time pressures on the physicians that may be a barrier to evaluation of dyspnea. How can we change behaviors among the 25 to 40% who are not doing this on a regular basis?
Well, that is a fantastic question, and it's one that we continue to struggle with. And for example, at my center, in terms of just quantification of dyspnea, the number of hurdles that I had to overcome to institute a regular screening for a quantification of dyspnea just in my clinic was pretty substantial in terms of, and so I think part of it is generating a continued awareness on the importance of shortness of breath for our physicians and our nurses and nurse practitioners, physicians assistants, so that we understand the importance of that, much like we did place the emphasis on the pain scales in years past. But I think once we've established everyone the importance of that, much like the government did with pain, then we can start to move forward in a much more regular basis. I think with the development of electronic medical records, placing that in is part of the electronic medical record in, say, for example, in the vital signs or the subjective portion of the history, as just a click tab would make it a lot more useful or a lot more user friendly and less time intensive.
Great. Thank you for that, Dr. Test. Another question. Now, you talked about it in the discussion there, but can you go into it a little bit more deeply? Is there a need for new tools to evaluate dyspnea in the practice setting? And there's a follow-up to that. How would these tools need to evolve?
Well, one of I do think there is an ongoing need for the development of new tools. We do have excellent tools to quantify dyspnea that span across disease states. Most of the respiratory questionnaires and dyspnea scales were originally designed to focus on one particular disease type, and that is one of the hurdles, and particularly when you deal with super specialties and ranking quality of life and symptoms, is are those scales applicable to a different disease stage? So, for example, something that might be applicable in COPD and interstitial pulmonary fibrosis, is it applicable in pulmonary vascular disease? And I think some of the more simple scales, the board scale, for example, or the MMRC, should be able to be applicable across multiple disease states. But I think one of the hurdles to overcome is proving that, or developing new scales which are simple and take very little time. I think that is the crucial thing to make any of these scales get them into wide use. And because if they take more than just a few minutes in this day and age when we're all forced to see patients at very high volumes, then the scale won't be used.
Great. There's actually another tool question here. It sounds like it's a follow-up to that question. Is do we need a tool that can be effectively used in multiple settings, i.e. primary care, pulmonology, cardiology, so that there is consistency?
Well, I think that, yes, absolutely. I think the Borg scale and the MMRC would apply to that. We should be able to be applicable in other disease states, although that's not, to my knowledge, ever been proven. And I think they could be used in multiple practice settings. But, for example, if you take, if we're able to narrow it down to a 3-question binomial sort of rating system that would take 30 seconds to do or 15 seconds to do, I think that we could prove that spanned across different disease states and specialties, that would improve our applicability of these sort of rating scales.
Great. One more coming in. Someone's typing, so I'll wait for them to finish. Okay. Hopefully I read this right. In your clusters, bypassers seem like a hardcore non-assessment group. Acknowledgers, however, see dyspnea as an issue. how do we influence this group more?
Well, I'm glad that question was asked, because when we were going over the data and when we were discussing it among some of the chest leadership, we asked those very same questions. I think the first thing to ask is, the bypass. Is there anything that would influence the bypassers? In general, when people are, ardently in one group, they tend not to respond to change behavior. So therefore, we would, for that group, I think the real importance is emphasizing the importance of dyspnea from the very beginning of medical training. Chest pain, for example, is a very important symptom, which has got wide recognition both among patients, families, and physicians. Is just the awareness of it as an importance of symptom begins from even before the student goes to medical school or nursing school. But dyspnea, we don't do that. And I think that would be the first step to try to sort of lure in and prevent people from becoming bypassers. The acknowledgers, on the other hand, I think we have the opportunity to reach out to, and I think there have been a number of studies over the years that look at the importance of dyspnea as a symptom. Some of them are now two decades old, but increasing the awareness of those studies might reach to some of the acknowledgers and push them more towards the responders.
Great. We have one more question. So dyspnea is a multidisciplinary issue, but often is evaluated on a single specialty basis, where the patients bounce from one's specialist to the next. Given the significance of a single specialty practice, how can we break down the walls between these different specialties? Specialists.
Well, I think that is a tremendous question. I said it before many times that I could probably make a living seeing patients who had been evaluated in other centers and told that their lungs were normal and that their heart was normal, but yet they have shortness of breath. A multidisciplinary center or a multidisciplinary approach or interdisciplinary approach doesn't require, of course, a common geographical area or center. What it really requires is confidence in your colleagues and open communication. I think the other issue, and this is the most important, is it requires a champion. So when I see patients with dyspnea, I push until I have the answer. I seek out the answer until I find it. And sometimes that involves the use of consultants in neurology or in cardiology or rheumatology. But becoming the champion in a given area and developing the communication and respect back and forth with colleagues, I think, is the first step in this program. I think if insurance companies and health systems were to recognize the importance of dyspnea on mortality, morbidity, and, for example, even cardiovascular morbidity and mortality, then we would get more momentum towards developing interdisciplinary clinics. But like most things, it will always require that someone be the champion.
Great. Well put, Dr. Test. Are there any more questions that we can ask Dr. Test before we wrap it up? It looks like that's it for today, Victor.
Right.
I want to thank you once again for your dedication and guidance in this this research study on dyspnea or shortness of breath. It's just the tip of the iceberg. We have an upcoming issue, a secondary issue on dyspnea coming out this winter. So again, thank you very much for your dedication to this topic.
Well, thank you. It's been my pleasure, and I appreciate CHEST's support as we chase down this very important disease state and symptom.
Great. And to the attendees, thank you for attending and participating. All attendees will receive a recorded link to this webinar. And if you're interested in purchasing this actual issue of CHEST Clinical Perspectives, please visit CHEST. Please visit insights.chestnet.org. So we are done. Again, thank you for your participation.
All right. Thanks so much.